a quick injury short today on the knee. Just a couple things that we tend to see in clinic. One of the first things we look at with the knee is knee flexion. So we want to be able to see a knee where I can bring the heel all the way in and touch the butt. A lot of times that movement will be limited. It'll be really stiff, oftentimes painful. A couple reasons for that. The meniscal cartilage in the knee. There's two semicircular discs of cartilage that fit into the knee between the femur and the tibia. That's what forms the hinge joint. They act as shock absorbers. You can actually get an entrapment of that cartilage. The cartilage has to slide backwards as we flex the knee, so that cartilage slides backwards. When we extend the knee, the cartilage has to move forward. Oftentimes we'll develop scar tissue between the soft tissues of the knee, the joint capsule, which is basically like the shrink wrap around the joint, and those structures get glued together, and that prevents the meniscus from sliding. So that can be a source of pinching pain in the knee. We can see that in the front inside and front outside, and also in the back on both knees. Certainly with any kind of a significant arthritic change in the knee, we'll tend to see some stiffness in through here as well. Another thing to think about is having just as little as 1 or 2 tablespoons of fluid in the knee, and that usually comes in the form of inflammation. That can cause the knee itself to be very stiff and painful. Sometimes we'll see things like a Baker cyst, which is a fluid-filled sac in the back of the knee. If that gets big enough, that'll prevent full range of motion in the knee. And we often see those associated with meniscal tears behind the knee, what we call a posterior meniscal tear. So the thing about meniscal tears is some require surgery, most can be treated conservatively. The meniscus doesn't have very good blood flow. So if the tears are on the outside and they're very small, we can usually do some manipulative and mobility techniques to the knee, as well as the foot and ankle and the hip, to help to just create better joint mechanics. And oftentimes we can get the patient rehabilitated conservatively without surgery. The other thing to think about is what we consider cardiometabolic factors. And those are things like poor blood sugar handling, diabetes, peripheral vascular disease, obesity. We tend to see increased degeneration in the joint with that patient cohort. And basically what happens is those patients release inflammatory cytokines, which are inflammatory proteins in the joint tissues that actually wear down cartilage over time. So not all arthritic change in a joint is due to just wear and tear. There are other things. Latest research is showing these cardiometabolic factors can be at play as well. So there you have it, just a couple basic things. Catch you in the next video.